This is the Sonosite Behind the Scan webinar called Using Ultrasound to Evaluate the Medial Ankle. And this is the third and a four-part series about ankle ultrasound. And we'd love it if you could join us on Tuesday, October 11th for the final webinar, Using Ultrasound to Evaluate the Lateral Ankle. With that out of the way, I'll get today's presentation started. My name is Chris Pennell, and I'll be moderating today's webinar. Before we begin, please be advised all attendees are muted. You can type your questions into the Q&A box in the toolbar located at the bottom or the side of your screen, and we'll conduct a Q&A session at the end of the presentation and demonstration. This webinar will be recorded and archived for future reference on our webinars page. So here with us today, we have Daniel Shelton. Daniel is the Director of Musculoskeletal Market Development for Fujifilm Sonosite. Daniel has spent 18 years as a dedicated musculoskeletal sonographer, and 12 of those years have been here at Sonosite. He now leads musculoskeletal market development, where he works to spread the word about the benefits of point-of-care ultrasound. Today's webinar is going to be a very thorough examination of the medial ankle, so I'll go ahead and turn it over to Daniel and get started.
Thank you, Chris, for that introduction. And I'm just going to jump right into the slides because we have a lot to cover. Just to reiterate, the AIUM indications that we have gone over in the previous webinars are listed here, and I won't exhaust the list verbally again. And then we're going to cover the medial ankle protocol set forth by the AIUM. It includes the posterior tibialis tendon, flexor digitorum longus, flexor hallucis longus, tendon, the tibial nerve, and the deltoid ligament complex. So let's talk about this medial ankle joint. As we do all these other structures, start at the joint level, start on the bones, and we're going to work our way superficially. That's the best way to navigate anything in MSK ultrasound because our bones are our roadmap and they don't change. So for the most part, I should say, but soft tissue changes, and that's why it's really tough on especially medial ankle when there's pathology to start superficially and work your way down, because in normal cases it's going to look okay, it's fine. But when you're really trying to traverse difficult terrain, when soft tissues are disrupted, ruptured, swollen, have calcium deposits where they don't belong, things aren't moving the way they should, really you have to start with your roadmap, and that's the bones. So let's start with the cortical landmarks first of the tibia. The fibula won't be a part of this exam, but the talus is a big part of the exam. So the tibia and the talus are a huge part of the exam. The calcaneus and navicular are kind of secondary to the majority of the exam, but the star of the show by far is the tibia and how the talus is secured to it, along with how the calcaneus and the navicular have their contributions to this ankle joint. So let's start with the medial ankle ligaments. And I will say this in advance, these are the most challenging parts of the whole medial ankle. So if you can get through the complex anatomy, or at least have a general understanding that these ligaments run in a particular orientation, and you have to have the ankle positioned in a particular way to visualize them, I think you'll have a great time learning and navigating these medial ankle ligaments. First and foremost, the deltoid ligament complex is a complex. It is shaped like a delta or a triangle, and that's why we think of it that way. It has nothing to do with, delta as a number or anything like that, but this is a large triangular ligament complex. And deep, we have two ligaments. They have a similar name, so it's easy to remember. There is a posterior tibio-talar ligament and an anterior tibio-talar ligament. So just remember those two. There's a posterior and an anterior. We never hardly focus so much on this anterior guy, but the posterior one is much easier to visualize as long as you've got the foot in the right spot. And just know that from a stabilization standpoint, these two guys are definitely keeping the joint from everting or opening too much, and that's very clear, and you can see that with the anatomy here. But here's our two ligaments we're going to focus on, and then the superficial structures to come. The first superficial ligament, it just parallels the deep posterior tibio-talar, and that is the superficial tibio-talar, so easy to remember. They are a complex. Unless there's something wrong with them, I will say you will not discern much of a difference between these layers. You can try to move and mobilize the ankle joint, and you might see some differences in the layers there, but I will say don't get frustrated if you don't see a clear delineation between the two. A lot of anatomical references don't focus on this anyways. They don't really even cite this ligament. It's potentially a little bit variant, but it does blend into its neighbor very easily, and its neighbor kind of steals the show. But let's take a look at what this looks like on ultrasound. Here's our transducer position. Here's the ligament here. You won't see this with a relaxed ankle. With a relaxed ankle, this ligament is tucked and is hiding under the medial malleolus, and you won't see it. So we need pretty exaggerated dorsiflexion. Keep part of your transducer planted on the medial malleolus, and just keep an eye for the talus to do all the mobilization. You should see that that subtalar joint right here swing into view just as a landmark in the FHL back here. We're not going to focus on the soft tissues just yet, but here's your cortical references. Here's the superficial and the deep. They do blend together, as you can see here. We're just talking differences in anisotropic artifact between these two. They are a complex, so don't get too hung up on saying here's deep, here's superficial. Just here's your probe position, here's dorsiflexion to find them, and in the live study, live scan today, we're going to go over that really nicely. Its neighbor kind of steals the show. It's the strongest ligament. This is the tibiocalcaneal. It is larger and broader. It is thick and dense. It does show up nicely with anisotropic artifact, but again, it's a part of this complex. So if there's nothing wrong with the ankle ligaments that you're ultrasounding, you're not going to see this huge delineation between the layers. But here's what it looks like on ultrasound. So here's our tibia, here's our calcaneus, here's the talus here, so it bridges that gap. Here's an anisotropic or oblique deep tibiotalar ligament. Just so we're running our transducer slightly more anterior than we began. We are a bit more mid-coronal in the shot here. So focusing on our cortical landmarks first, you're going to plant the proximal aspect of the transducer and swing the distal aspect until you see the calcaneus, specifically around that sustenaculum tali portion of the calcaneus. Its neighbor here is now the tibiospring. This is where it gets a little bit more complicated. Down here, joining the calcaneus to the navicular, is the spring ligament complex. It's not the star of the show today. It's not the deltoid complex that we're here talking about, and it's not a part of the AIUM protocol to evaluate the spring ligament with any level of detail. But we do need to know about the spring ligament because this is the only ligament in the ankle that has a bony origin, but a ligamentous insertion. So it inserts on the spring ligament. So this is the tibio-spring ligament. So spring ligament acts as a hammock for the talus, and it has these fibers that literally act as a hammock and hold the talus in position, creating this very secure archway, or underneath hammock, I guess is really the only way to describe it. But superficial to this, and blending and merging and interdigitating with this, is the tibiospring. It's very long. It goes all the way down here to the undersurface of the articular cartilage surface of the talus. So anytime we see the talus and then we see the cartilage, if you see the cartilage, the immediate superficial surface to that cartilage is most likely part of the tibiospring in an oblique fashion, depending on how you have your transducer situated. But spring ligament, it's going to go from that sustenaculum tali region of the calcaneus, the inferior, more anterior portion of it, to the navicular. And then it also has branches that kind of go on the superior, superficial surface of the navicular, but mostly it also acts as a hammock in its insertion across the undersurface of the navicular. So it's a big, broad ligament underneath the talus, and then this tibiospring ligament attaches to its fibers kind of mid-hammock. So here's the probe orientation. We're aiming from the arch of the foot up. So superior lateral, I guess, would be the angle. So the probe is laying inferior medial, aiming superior lateral. We're then going to fan the transducer tail, or the handle of the probe, up and down until we see these landmarks come into play. If you see that talus cartilage, you're really, really close. Then I need you to fan your distal portion of the transducer here until we see the navicular, the more superficial guy, And then deep, we're going to see the calcaneus and the sustenaculatalia of the calcaneus show itself. And just as a landmark, here's the flexor digitorum longus sitting on top of it. And then as another landmark up here to the navicular side, we can see an oblique posterior tibial tendon, which we'll get into after we get out of these ligaments. But here's the talus. Here's that spring ligament complex. It's all of this. Even though we see one really nice cord of fibers coming into play, this is all still part of that ligament complex underneath. So it's just not what we're focusing on here. We see that really nice central cord bridging these two bones. And then we need to keep in mind that tibio-spring ligament is now coming at us. So we're seeing a cross section of the tibio-spring ligament here. So we're going to rotate our transducer, and we'll do that in the live study. And now we have a cross section of the spring ligament, which is here. And then we have that interdigitated tibio-spring ligament. So here's tibia, here's the neck of the talus, and then incidentally, actually what we're seeing here is a bit of the tibio-navicular ligament superficially, and a bit of the tibio-talar ligament anteriorly, the deep tibio-talar. So we're not focusing on those, but that is what's sandwiching the tibio-spring. So in this particular slide, we're going to windshield wiper the distal aspect of the probe. We're going to plant the tibia side of the probe. And we're going to swing it across until we see navicular superficially, and then we're going to swing it back until we see the calcaneus deep. And then we're going to split the difference between those two and do a dynamic maneuver next. So here's that slide. So here's superficial navicular, and then here's the deep portion as we slide back across to the calcaneus, sustenaculatalia, the calcaneus comes into play, and then we're going to split the difference between those two and rest our transducer right there in the middle, and then we're going to do this dynamic maneuver. So we're going to invert the foot, and what that's going to do is kind of try to clap the calcaneus and the navicular together. So I want you to grab the distal foot and pull it inward towards the arch and towards the calcaneus, and try to get these two bones to touch. And that's going to relax the tightness of the spring ligament a little bit, enough to cause it to stretch and to contract here on the tibio-spring side. So I'm going to hit play, and I want you to watch this central band right here. So here's the spring ligament complex hugging the cartilage. Here's some inferior fibers of the posterior tibialis tendon. And they're anisotropic. So you can see this interface when we start inverting the foot. You'll see a glide here, but particularly I want you to watch this structure here bounce on top of the deep tibio-talar ligament and underneath the tibio-navicular oblique segment here, which we're not focusing on. We're focusing on this central portion going to the tibio-spring complex right here. So spring complex, tibia, follow these fibers when we invert, and that's what we're seeing here. So watch that bounce right here as it relaxes and stretches, relaxes and stretches. And you can see these fibers and how they're connected. And the beauty of ultrasound is that we have the ability to make these tissues move, and sometimes that's the only time you can delineate structures. Even on MRI, there's lots of notes in the radiology references about how some of these ligaments, you really can't distinguish one from the other. And that's the same with ultrasound in a lot of cases on a static image. If there's no pathology, they don't make themselves very discernible. But I will say ultrasound has the advantage in that we get to make the tissues move, and those movements can oppose the surrounding tissues. And that's what we're seeing here. We're seeing the bulk of the navicular shadow over here pushing that posterior tibialis tendon and the tibio-navicular ligament complex. All of this up here is moving separate from the spring. So we can see the spring ligament. We're relatively cross-section to the spring ligament here, and you can see that insertion to the spring complex of the tibio-spring. So tibio-spring sandwiched between these two other ligaments that are not the star of the slide here. But that's one way, a very useful way to evaluate tibio-spring if it's something that you're working on. Next is the tibio-navicular. So this one is, I would say, the more challenging of the deltoid ligament complex to see because it's so thin. I typically don't focus on it. I will admit I sometimes even skip it if I don't have anything to look at in that area. I'm basically windshield wipering all the way across this portion and doing those dynamic maneuvers. And if I don't notice anything anterior to that tibio-spring area, then I really don't go much further anterior if there's no reason to. But just for the sake of being thorough, let's go ahead and show you what that looks like on the slides. So if you did see tibial spring in the last slide and you did see the shadow of the navicular starting to come into play, we were already climbing into the tibio-navicular portion, which is extremely thin, hard to see, and you can rock your transducer around and get this fat to move on top. That's one way to kind of see what the superficial aspect of it might look like. And then deep to that, you know, we're invading that tibio-talar, deep tibio-talar ligament area here on the talus. So that's one way to kind of find out what's on top and bottom of it. But I don't take an incredible amount of time looking for this one. If there's nothing wrong in the area, there's really nothing to stop and beat your head over about. So just kind of move along what looks like a fascial plane, abridging the tibia to the navicular. And then the most anterior one, which we had covered earlier when we were sweeping through, was the tibio-talar ligament, and we'll cover it further in the live demo for the sake of time. So with that, I'm going to switch over to the studio and get us set up for the live demo. All right, so we'll start with the live demo, but before we get started, I want to discuss the transducer options here. The main transducer we're probably going to use the most is the L15 to 4. That is a 15 megahertz to 4 megahertz range. We're very shallow, but the length of the transducer is very handy with the long axis of these tendons and even the ankle ligaments in some areas, like the anterior tibio-navicular portion is particularly long. So the long footprint is very advantageous here in some cases. Other cases, we're going to get around the bonier malleolus by switching over to the L19 to 5 transducer. So that's a 19 megahertz top end frequency, but its small footprint is very advantageous around the malleolus. And we typically run out of gel contact right here around that that part right at the malleolus. So I'll just kind of show you what I'm talking about. There's typically an air gap with the larger linear array transducer. So when we do that, here we get a big air gap around the malleolus, and instead of always filling in with more gel, switching over to the smaller footprint 19 to 5 megahertz transducers is very nice. And then I like the traditional handle of the 19 to 5 rather than a hockey stick for long to short axis scanning. Very easy to segue back and forth for diagnostic and interventional procedures. But we'll start with the 15 to 4, which is what's hooked up. I'm going to grab some ultrasound gel here, and we'll get started. We're going to work our way from deep to superficial, just like in the PowerPoint. So again, we're going to start on the bony landmarks and then the ligament evaluation, working our way up to the tendons and then the neurovascular structures. So I like to wrap my arm around the cord and get a lot of this cord out of the way. I do palpate the malleolus while I scan a lot of these. I am going to keep the left side of the screen anterior just to keep it consistent with the slides. And I like to start on the back side of the malleolus in a relative cross section. All right, so left side of the screen, let me get my arrow up and going. We've got the medial malleolus. Okay, let's fall off that and look for the next cortical landmark posterior to the medial malleolus. Here's the talus. So as I swept and windshield wipered the transducer proximally more axial, that is just tibia. So this is all tibia. And then as I go distally, let's fall off of the medial malleolus of the tibia. The next bone here is the talus. And then if I keep climbing distally, we'll encounter another joint back here, and then the neck of the calcaneus, just to give you an idea. That was all axial scanning there. And if I go long axis scanning on the tibia, I see the distal portion of the tibia, the medial malleolus of the tibia, and then if I fall off, there we go. Here's talus again, so tibio, talar, and then there's a joint that we see here, and then we start to see the calcaneus come in. And if I sweep the probe this way now, distal side of the probe, right side of the screen, more posterior, we elongate that neck of the calcaneus again as another reference point. So just kind of getting those bony joints road mapped out. Let's go anterior with this just a little bit. So as we looked at the ligaments on the anterior side, anterior superficial deltoid, which would be the tibio-talar. Here's our distal malleolus again, and then you can see where that bony interface causes the air gap there. So we're going to add a bead of gel right there where I saw my transducer let up pressure, which is another tip you can do if you don't see all of your scanning landmarks while you're scanning because of an air gap like that. You can give it a little bit of pressure on the sides that you are getting image, and then when you let up, you're left with this rectangle, and that'll be a good spot to lay down a bead of gel right on the rectangle. That way you end up with a really nice gel standoff like we have here. So medial malleolus, anterior talus with a little bit of the cartilage, and then the navicular starts over. That's probably the medial-most cuneiform there. Navicular would be just a bit more medial. There we go. So talus, navicular, just to introduce those bones as we scan. So now that we have the bones oriented, especially the talus, that's going to be a big landmark here. You can see that big cartilaginous interface of the talus's articulating surface with the navicular here. We'll climb back up on the medial malleolus and start scanning some of these ligaments. I think this first ligament is the easiest one to scan. It's a deep deltoid ligament. It is posterior. When the ankle is relaxed like this, it's difficult to see. The ligament's tucked up under the malleolus, and it's very hard to see. So we're going to fall off the medial malleolus just enough to where I start seeing that shadow, and then I've got the talus in orientation here, and what I'm going to do is just have our patient dorsiflex, and that brings that deeper deltoid ligament out. So this is our posterior tibiotalar ligament, and it is a deep ligament here. And then keeping that same dorsiflexion going, I'm just going to pivot all the way around until I see the anterior. Let's go ahead and drop the front of the foot until we see that deep deltoid ligament of the anterior tibiotalar ligament. And so I should see a little bit of a portion of the anterior talar cartilage like we did on the anterior ankle where we saw the ATFL. Well, this will be the anterior tibiotalar right here. So we can see that deep ligament here. I'm just going to stress the ankle just a little bit more just to see that deeper deltoid shadow right where my arrow is. There, right under there. And actually what I'm going to do is push down with my palm. You can see my palm down here on the foot and provide just a little bit of stress. So there, I'm just kind of pushing down. And what I want to do is show these soft tissues up here. Some of this is fat. There we go. And I'm trying to find and delineate that shadow of that deeper ligament layer right here. So this deep shadow diving is an anisotropic shadow of that anterior tibiotalar ligament. Here's the cartilage of the talus. Nothing's attaching there. And then there's a little bump, little tubercle there. And that would be where it inserts. So that takes care of the deep layers of the deltoid ligament. Let's go to the superficial layers. So back up to the medial malleolus, relatively posterior. It's not going to be superficial to that first easy ligament, not necessarily, but we're going to follow it and use it as a roadmap. So here's our medial malleolus, here's our talus. Now we're looking for the portion that jumps over the talus to the calcaneus portion. So this is the sustenaculum talli of the calcaneus. And just to check our work on that, it looks like another medial malleolus. That's one way to kind of distinguish it. Number two, we'll get to the FHL, the flexor hallucis, as long as it sits on this neck. And I'm just going to wiggle the big toe. So when I see that landmark right here, I know to abridge these two. So medial malleolus, sustenaculum talli, and we should get that superficial tibiocalcaneus, tibiocalcaneal portion of the superficial deltoid complex here. Really nice fibers. Sometimes inverting, dorsiflexion, just to delineate these layers. So what I'm going to do is use my hand over here, and I just want to see this layer move relative to the tissues around it. Not much. Again, there's not anything wrong with this ankle and its ligaments, so we're not going to find a lot of distinguishing layers until there's actually acute injury or even chronic injury. Let's move on to the, let's introduce the spring ligament really quick because it is our landmark for the tibiospring. So if I'm scanning posteriorly here, and I find that sustenaculum talli of the calcaneus right there, so you can see that big bony neck on the calcaneus portion. And what I'm going to do is plant that portion of my transducer. Okay, so that is the smooth side of the transducer, or the right side of the screen. I'm going to plant that part, and now I'm going to windshield wiper and swing the dot side of the probe, which is this part here with the orientation marker. We're going to drop that down, and we should see, there we go, see the cartilage of the talus. That's one landmark. We're almost there. So here's the cartilage of the talus, and I'm going to fall down just another bony landmark, and that should be the navicular. And so here's the navicular, here's the sustanaculum tali of the calcaneus, and that's where we start to see this ligament complex creating this nice hammock. It's an upside down hammock, basically. So it's not supporting the structure superficial to it as much as it is holding with, you know, if the foot were load bearing, this talar cartilage, this whole interface would be pushing down on the spring ligament here. And the spring ligament's very important to go ahead and map out, because superficial to that, there's a ligament complex attaching to it in transverse. So we see this transverse kind of oval egg looking structure, and that is the tibio-spring ligament portion of the superficial deltoid complex. And we're going to trace that proximally up to the malleolus in long axis. So I'm going to spin this transducer around this ligament portion. It's the only, the tibial spring is the only ligament portion that attaches to a ligament instead of a bone in this part of the ankle. So let's follow that anisotropic shadow. So just superficial to it as a landmark is the PTT, that posterior tibialis tendon that we'll get to. Underneath that, that really dense anisotropic area here is the tibial spring as it heads up towards the medial malleolus. There we go. So here you can see the fibers very, very shallow. Some of them are diving and fanning out. It is a pretty broad ligament, and you can start to see them attaching into this complex. All this area here is that complex that we just looked at. The cartilage of the talus down here being another good landmark. So tibial spring ligament here, PTT, or tibialis posterior right here. So there they are, just bordering each other. And then the next one, the most difficult one to scan, and I honestly don't spend hardly any time looking for this one unless there's an injury here. So if we don't see it with confidence here today, don't stress too much about it. But we're going to go to the anterior part of the medial malleolus. Okay, we're going to bridge all that gel over to the navicular. So we see the navicular here and the talus here. And what I'm looking for are, and I'm pushing down with my palm. So I'm going to push down and stretch this ligament as much as I can. And one of my goals here is to distinguish tissue movement, stationary tissues to tissues that are moving while I scan. So it's just another tool in your toolbox to add dynamic maneuvers and try to get these tissues to move across each other. And when in doubt, just keep adding gel, and the image just gets better and better and better, right? All right, so medial malleolus, following the superficial fibers. So this is the tibialis posterior tendon. So I've gone too far posterior. Now I'm going to move anterior to that. So right there on that anterior kind of facet of the medial malleolus. Once I see some anechoic anisotropic fibers trying to attach there, I'm going to windshield wiper the distal portion up and over this talus neck as much as I can to the navicular portion until I see some fibers distinguish themselves. And there's no injury here. Again, it's hard to see this particular ligament, and most of the references out there just kind of skip over it in their ultrasound exam. So don't get discouraged if it doesn't just hop right out at you. But here you can see the connective tissues moving over this cartilage of the talus. So watch this band as it hugs the talus and slides up and over the cartilage portion over to the navicular. We're going to look at the tissue movement here when I push down on that first metatarsal right there. So that is about as good amount of movement as I can get the ligament to show itself. It's just not super thick. It is more broad than thick, which leads me to tell you it's much more easy to discern each of the ligament layers from the anterior-most surface of the medial malleolus right up here. Follow the shadow right here. So we're cross-section to the medial malleolus, and we're going to fall off the medial malleolus distally. So medial malleolus, let's fall off of it, and let's use the anisotropic shadows of the deltoid ligament complex to our advantage. So I'm just teetering the probe distal proximal in probably 1/2 centimeter increments. And I'm looking for volume loss. I'm looking for herniating tissues. I'm looking for the anisotropic artifact that we see here of the deeper portion of the deltoid complex and the superficial portion of the deltoid complex to discern which is which. Here's the anterior part of the medial malleolus, so that would be the tibionavicular portion. The middle section, we're going to fall down into tibiospring right in here, and then the posterior portion of that is that bigger tibiocalcaneal portion, which is the biggest, strongest one, easiest to see. And then the deeper layers under here show up better when we have dorsiflexion. So if I had our patient dorsiflex, those will tighten up, and they're almost relatively horizontal to the back side of the ankle anyways, which I've got my transducer flipped from earlier there. So way easier to see that posterior tibiotalar in dorsiflexion, and the anterior tibiotalar in plantar flexion there. But it's this whole complex. Stay hugged around the medial malleolus, scanning like this, and then also check in cross section as often as you can. So we'll start now on the tendons of the medial ankle and get back to the live scan. All right, so here we are back to the slides. Medial ankle tendons are next, and thankfully I will say this is easier. The deltoid ligament complex is the most difficult thing. Sorry to throw you into that head first, but anytime you're scanning something new in musculoskeletal ultrasound, you should work your way from the bones and work your way superficially into these soft tissues. These are the most variable items that you're going to scan, are the superficial soft tissue structures like ligaments, like tendons, tenosynovitis, synovial sheaths, and the surrounding fat. So let's dive into the tendons. Much easier to look at when you are scanning these. If you start at the malleolar level in cross section, they all line up very nicely, and I mentioned that in the last webinar, and the anterior ankle in particular, that if we're scanning all of these crazy tendons in the ankle and you start in your cross section and at the mid malleolar level, it's very simple to just pan your transducer distal proximal and see these structures stay in the center of the screen before they start going off their various directions. So we're going to focus on the medial malleolus first and then work our way posteriorly out into these soft tissues. So this is the tibialis posterior, also called the posterior tibialis tendon. In all the references, you'll see it called the PTT. So that is the posterior tibialis tendon. Bordering it in parallel at the malleolar level is the flexor digitorum longus. It has a longest way to go. It does actually traverse this canal under here, some soft tissue landmarks that we'll talk about, called the knot of Henry, before it takes its immediate turn out to the digits in the bottom of the foot. But it does run in parallel to the posterior tibialis tendon at the